Welcome to this BTOG podcast. My name is Newsom-Davis and I'm a medical oncologist at Chelsea and Westminster Hospital in London. I'm vice chair of the BTOG steering committee. I hope by now that you know that this is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their field and we tackle the most important questions that we all face in the diagnosis and the treatment of thoracic cancers. It's important to say that the sponsors of BTOG do not in any way have any input to the planning, content, or delivery of anything that we discuss.
Hello, everyone, and welcome to another BTOG podcast. My name is Newsom-Davis. I'm a medical oncologist at Chelsea and Westminster Hospital. And today we're going to be talking about BRAF. And this is the first of a number of podcasts where I want to pick out on different mutations, perhaps the less common ones, the ones we don't see so frequently, but which are more and more important as we have treatments available for them. And I'm delighted to be joined by an international figure, none less than Jarushka Naidoo. Jarushka is as you might imagine, friend and supporter of BTOG. She's a medical oncologist and trained in Trinity College Dublin and did her training in Ireland, but then got lured across the pond to America, where she did fellowships at Memorial Sloan Kettering and masters at Johns Hopkins, and then got lured back to the Emerald Isle, where she is a medical oncologist at Beaumont Hospital. And in fact, I noticed you're a professor of the Royal College of Surgeons in Ireland since last December. So many congratulations, Professor. Thank you for joining us and welcome to our podcast.
It's great to be here. Thanks so much for the opportunity. Great idea to share information on this important subset of patients.
Thank you. Yeah, it's very interesting, BRAFs. So I'm going to put my hand up here and say I see very few patients with a BRAF V600E mutation. So you're the expert in the room here. I'm going to rewind a bit and we're going to go back to basics and tell me, what is BRAF in terms of what does it do in a cancer cell and what's its role, particularly in lung cancer?
Yeah, so BRAF, which is relevant obviously across tumor types, we've got most of our knowledge from the melanoma field, but now is applying to patients with lung cancer as well. So essentially it is a 95 kilodalton serine threonine kinase. So it's a
that one.
Exactly. It's a protein that exists in the MAP kinase pathway. So the RAS, RAF, MEK, ERK pathway, which is involved in a key oncogenic driver pathway that drives the growth and proliferation of cancer cells. BRAF is one of its intermediates, and it occurs downstream of RAS, but it can also signal independently of RAS. And there are several different sort of permutations of how BRAF can act in this pathway. And essentially, we know that in melanoma, about 40% of patients with melanoma have a BRAF mutation called a BRAF V600 mutation. In lung cancer, the incidence is far lower. So the incidence is around 3 to 4% of patients with lung cancer. And then in very interesting and important work from a very good researcher in the US, Ebiayi Jack at Mass General, she and others identified that BRAF mutations in lung cancer come in 3 different flavors: class 1, class 2, and class 3. And essentially class 1 is this V600 group, and that can be V600E, K, many different subtypes. And that is sort of more like a traditional oncogenic driver, one that happens enriched in female Asian never smokers and is associated with response to targeted therapy. Whereas class 2 and 3 are a little different.
Yeah. And we've known about these for a while because you mentioned in that introduction that our melanoma colleagues have been ahead of the game. They've known about this, they've targeted this. And in fact, we've known about BRAF as a driver of cancer for a long time, but actually, as we'll get onto in a minute, so we won't spoil the show, our licensed treatment in lung cancer has been comparatively recent. Tell me a little bit about, so you talk about those 3 classes, and I think that's a really, really important thing. Just for those who perhaps are less familiar with the molecular genetic side, I mean, how could you not be? But those who are less familiar, when we talk about V600, for example, V600E, what does that mean? What is the V, what's the E, and what's the 600?
Yeah, so really this tells us where the aberration is happening. So normally this is a change from a valine to a, so different protein products that are being changed at a certain place in the codon. And so this occurs at chromosome 7. And essentially it's the 600 codon, and it is an exchange between the two. And usually that might imply some differences in response to therapy. We could get into a big quagmire about that, but I think what is good for those who are learning about this is to also be familiar with these oncogene databases that can help us to understand these a little bit better. So cBioportal, OncoKB, these are freely available databases and constructs that allow you to type in, lung cancer BRAF and all the different permutations, and to show you the category level of data that supports the different targeted therapies or other therapies that may be suitable for the different subclasses. So not trying to make anybody out there a molecular pathologist, but to give you the tools to be able to understand.
That's a really good point. Also, My Cancer Genome is a very good one. And I think you're right. If you don't know what it is, look it up, because why wouldn't you? Okay, so if you're going to get your molecular pathology report back and it says V600 something, then we're happy, because there is going to be a targetable mutation we have something for, and we'll get onto that in a second. There are the class 2, the class 3 changes for which are relevant in the cancer, but we don't currently have licensed treatments for them. Is that a fair thing to say?
Fair thing to say. I think another thing that's important to understand about class 2 and 3 is when we think about oncogenic driver mutations, generally we think they are mutually exclusive, meaning if you have an EGFR sensitizing mutation, it is unlikely that you're going to have a co-occurring alteration somewhere else. Not saying it can't happen, but the incidence of a co-alteration is very, very rare. This is not true of BRAF. So for class 2 and class 3 alterations, it is co-alterations are seen, particularly in PIK3CA, NF1 in the instance of class 2, and in class 3, about 50% of them will have co-occurring KRAS mutations, and often their KRAS is sort of, is a major driver too. So that is a little bit different, and something that can be confusing, for folks who are ordering NGS testing and interpreting that.
So if in doubt, read it carefully. If you don't understand your report, phone your molecular pathologist, speak to a colleague, don't be shy, and make sure you know what you're treating. Okay, so you mentioned they're uncommon, 3 to 5%. Certainly in my patch, we get actually much less than that. Who does get it? Is this adenos? Is this squames? Are these smokers, non-smokers? What might be your typical patient?
Yeah, great question. So I think the class 1 mutation, the BRAF V600 mutations, happen in those whom you typically associate with driver-associated lung cancer. So generally, female Asian never smoker is enriched in that population. The class 2s and 3s are in a more typical lung cancer population, male smoker adeno. So if you grouped all of the BRAFs together, because there's more of the class 2, and with 50% or slightly more might be class 2 or 3, it might appear that BRAF alterations in general happen in male smoker adenos, but it depends on understanding that class. But in general, we should test, or it should be customary to test for BRAF in our list of alterations for any non-squamous non-small cell lung cancer.
And would you ever test in squamous patients? Is there any point in that? If you had a young non-smoking squamous patient, would you test, or is it so unlikely as to be a bit of a waste of everyone's time?
So I think in the Asian, female Asian never smoker population, it would be important to do NGS, to do a broad panel, and that generally will include BRAF. However, most of the times, if we're going to find an alteration in the squames, it's generally EGFR or ALK. I'm not aware of squames having BRAF, but stand to be corrected. With the more NGS we do, hopefully we might be finding these unusual circumstances.
Yeah, I agree. And the only one I've seen in a squame has been MET exon 14. I've seen that in a very small number of people. Yeah. Okay, so that tells a little bit who it's for. But as you say, I think we would hope that most of us now are doing reflex molecular testing on our patients with advanced or locally advanced non-squamous. How do we diagnose it? Is this immunohistochemistry? Is this NGS? What kind of NGS? What should our colleagues be making sure that they are requesting?
Okay, so this is a DNA-based genomic alteration. So we have the two standard ways to test for this would be when we do hotspot testing, where we test for an individual alteration. It's generally done by ddPCR, digital droplet PCR, individual testing for a gene. Or in a more sort of, in a manner which allows us to be more efficient with tissue, which is always a key concern in patients with lung cancer where we don't get a lot of cells or a lot of DNA, then doing next generation sequencing is better because it allows us to test for alterations in a massive parallel way without minimizing the amount of tissue loss. So in this instance, it would be next generation sequencing. There is some data for doing BRAF IHC. However, it's only been assessed in class 1 alterations.
Okay.
So I think I have never seen it actually being used clinically. And I think in the context of how lung cancer is going, the use of NGS for the other relevant alterations, most of the time it's going to be ddPCR or NGS.
And do we know, and I have no idea what the answer is, maybe you do, maybe you don't. We know, for example, with EGFR exon 20 insertion mutations, that PCR is less good than NGS. You're going to miss rare variants. Do we have the same concern with PCR? And if we have colleagues who inverted commas only have PCR-based assays for their BRAF, should they be worried?
Yeah, truthfully, I don't know. I don't think that there's been a large enough experience published to be able to discern that.
No, I don't know.
So I don't know the answer to that one, but I would say BRAF, there isn't as much knowledge necessarily of, if I was doing an individual test and it came back negative, do I need to repeat? Yeah. I think if you're going to repeat in a never smoke, you're going to do the NGS anyway, and it might come up from there.
And I must say, I do think that all of us, as a rule, should be pushing our colleagues in our departments to be doing NGS. It is clear that is a better approach. You will miss mutations, other mutations with PCR-based assays. It's slower. Well, it's not necessarily slower, but you can also waste tissue. So, okay, so that's going to be on your DNA-based assays, and we're going to make sure that when we see the results, we're going to talk to our colleagues if we have any uncertainty about it. So imagine a situation, you have your non-smoking patient, you found your BRAF V600 something mutation. Our melanoma colleagues would be reaching for dabrafenib and trametinib together. Dab-tram is the abbreviation. It always makes me laugh. Do we use these? What's your view on dab-tram for lung BRAF V600 mutations?
So I'm a somewhat rare beast in that I have had several patients with BRAF V600 alterations. This was from my former life at Hopkins. So I actually had 5 patients with this, which I think is somewhat unusual even in the US, to be honest. And so I gave dabrafenib, trametinib to all of them, and I had, anyway, this is my own.
That makes you a world expert. I mean, you're basically right up there, yeah.
I appreciate, this is just my experience. It might not be everybody's experience, but I did have very good experience with it. I have one patient who still sends me a text every now and again, would you believe, is in a near CR. And this is 5 years later, with metastatic disease. So all of those patients actually had responses, some of variable duration. I think I'm certainly a believer. So where does this data come from? This came from a phase 2 study, David Blanchard, Lancet Oncology. And then we know that the 5-year data from that same phase 2 study was published in the JTO last year. And essentially the response rate is between 64 to 68%, depending on whether patients receive it in the treatment naive or the pre-treated situation. The most common toxicities, which is what this 5-year patient who makes me smile did have right in the beginning, and that was pyrexias. So pyrexia is definitely the most common toxicity of this, and it could be attributed to the dabrafenib or the trametinib. So we had to do a little bit of dose reduction on both sides, but got to a nice sweet spot, and she was, she's been maintained on it for a long time, and similar experience with others. I think what's very important to know here, just to drop that in, is This is still a subset of patients who may respond to immunotherapy or chemoimmunotherapy. So there's a constant tug of war, push-pull. Should I do the dabrafenib, trametinib first? Should I do chemo-IO followed by it? I think, in this circumstance, these patients may indeed respond to chemo-IO. So chemo-IO is not wrong. But I think when you sort of bought into that, well, this is targeted therapy for a target in lung cancer, you see a target, you want to treat the target, and there is good data for treatment naive. So in all of those patients, I've given them dabrafenib, trametinib first line and had good experience.
That is very interesting. I'm going to touch back on that immuno thing in a second, because that just made me think of something. You've got obviously a super responder in your patient cohort, and it's always fabulous to have those. But she probably is a super responder. By and large, what are we talking about efficacy? What's the broad response rate? What's the broad duration? Are we talking osimertinib type EGFR levels of activity, or are we talking about something more effective like ALK inhibitors or something less effective? What's your view?
Yeah, I think we're talking something slightly in between. So the response rate was dabrafenib, trametinib was 64 to 68%. And
that's pretty good.
Pretty good. Progression-free survival of about 10 months and overall survival of about 2 years, and where you've got about a quarter of patients alive at 5 years. So I think in general, very good. And in the EGFR type range, I would think, just that we don't see as many patients, so
absolutely.
Many don't have as much experience with it. But I think the tolerability, this is just a muscle we need to learn to flex. That we have to learn to get comfortable with dabrafenib, trametinib. I'm lucky the other tumor type I treat a small bit of is melanoma, so at least I have a lot of experience with that and comfortable with changing the doses around, and it's very similar in lung cancer.
And it's one thing that I often come across in my acute oncology work. Someone will come into A&E with pyrexias and the standard emergency department, and I'm not being critical of my colleagues because, of course, the number of drugs available is huge, will be immunotherapy, or chemotherapy-associated neutropenic sepsis. And, of course, they're not neutropenic, it isn't chemotherapy, but they do have pyrexias. So this is common, and what you're saying in that situation is obviously you want to make sure they're not septic, but it's such a common side effect, you just tend to hold one drug and wait and restart, or do you hold both and wait and restart?
So normally what I do is the most common offender that I've found is actually the trametinib, even though some of the data would suggest it's dabrafenib. So normally I would hold the trametinib first, check that this is indeed the drug that's causing the problem, and then institute a dose reduction of the trametinib. And then I do the same thing with dabrafenib after that. And usually we come to a dose that suits the patient from there.
Yeah. And away from the pyrexias, is this well tolerated? Are we talking GI side effects? Do we have any concerns about, I don't know, pneumonitis or cardiac side effects? What's your experience?
So in general, GI, it appears to be nausea, vomiting, abnormal LFTs, sometimes a skin rash, some pedal edema. Pedal edema is probably the other one that I look out for, most commonly. But really the one that those of us who practice are going to see most commonly would be the pyrexias.
Yeah. And just to, I guess, very appetite for our website, so I appreciate it may not be relevant to Ireland and other places in elsewhere. The new NICE guidelines, which came out about 4 weeks ago, have finally recommended dab-tram as a first-line treatment for BRAF V600 mutated lung cancer. It's actually been available a little bit longer. If you're wondering, well, that's not new, I've had access to that. We had access temporarily during COVID as we moved away from chemo, but we now finally have the NICE approval, which is quite late because the data supporting its evidence, as you rightly say, was quite a while ago. But it's now available to all and sundry near and far. So you touched upon there what you might do maybe as an alternative or after dab-tram. You said chemo-IO would be a very reasonable option, and I agree completely. We do have some funding restrictions in the UK about who we can use chemo-IO on, but actually BRAF mutation is not one of the limitations, so you can use that. Imagine a scenario where you have a patient, your typical BRAF patient, who's got a PD-L1 of 100%. Are you going to throw in pembrolizumab or similar single-agent immunotherapy as your first-line treatment? Or should we be treating that high PD-L1 with equal caution as we do with EGFR, and in fact selecting a different treatment and probably a TKI? What's your
Yeah,
take?
so I think this goes back to the fundamental biology of the different alterations. So we know that class 2s and 3s happen more in those who may have smoked in their lives and with co-occurring RAS mutations. And in general, class 2 and 3 BRAF altered lung cancer has a high TMB. So you're dealing with a biologically different type of BRAF mutation. So the data for this comes from the Immunotarget Registry, which is a large French-based registry that examined the outcomes of immunotherapy in these different oncogene-addicted subsets. And essentially what they showed is that BRAF V600 alone, when you give immunotherapy alone, the median PFS is low, one and a half months or something like this.
But essentially futile.
Exactly. Whereas class 2 and 3, it was more typical, 5 to 6 months. So I think, IO alone in that sort of class of BRAF mutation can be entertained. I think in those with BRAF V600 mutations, even if the PD-L1 was high, I would be very wary of that.
Yeah. I absolutely agree with you.
We know that oncogenic drivers can constitutively upregulate PD-L1. That hasn't been shown in the context of BRAF, but certainly in EGFR and ALK. So I would definitely be wary of that.
And this is a theme we often hear. We hear that in a lot of our educational things through BTOG, and I certainly hear it in clinics. You see someone in clinic, you go through the results, they've done their reading, and they want immunotherapy with their high PD-L1, but they've got, for example, an EGFR mutation. I think it's important to stick to your guns and say, immunotherapy is great for the right people, but it's useless for the wrong people. So I'd agree with you completely. I think with the V600s, I wouldn't use it, single agent.
Conversations can be hard to have. And for those who are listening out there, it's a double-edged sword, I would say. The immunotherapy getting good game out there is a good thing. It means people are more open to treatment, but also sometimes it does mean this nuance of which patients does it suit, and also the perception of, well, this doesn't cause any toxicity at all, and then they get a dramatic IO toxicity. I think it's important to try to level the playing field when you talk to your patient when it comes to any treatment, but particularly immunotherapy because of public perception.
Yeah, no, I absolutely agree with that. So we're going to use our DAB tram first if we have access to it, and I hope all colleagues listening do. After that has progressed, and assuming there are no localized therapies, you'd be switching systemic treatment. Are you moving to platinum-based chemotherapy in some form, plus or minus immunotherapy? Would that be your take?
Yes, I'd say in most cases, this is what I'll do. The other thing to say, actually, just to flesh out the dabrafenib trametinib or BRAF-MEK combination, is a new phase 2 study was published only a couple of weeks ago in the JTO of the other BRAF-MEK combination, encorafenib and binimetinib.
Yeah.
This was a phase 2 trial that was led by Greg Riley at Sloan Kettering, also a phase 2 study of this combination, and really just, very similar agents, 98 patients, 59 treatment naive, 39 pre-treated, and again, very similar, maybe, well, we don't want to overcall it, but slightly higher response rate, 75% treatment naive, 46% in the pre-treated population. So maybe increasing the argument for trying targeted therapy first. Importantly, the toxicities are slightly different. So here we're seeing more nausea, more diarrhea. Diarrhea isn't really something you see with dabrafenib, trametinib. And, in that example, there was one fatality, actually an intracranial hemorrhage fatality, but just more fuel to the fire that dabrafenib, trametinib or BRAF-MEK inhibition first line is probably going to be the way to go.
And in that study, and you read my mind because I was going to mention it to you, because it was presented at ASCO, in fact, in a month or two ago. And 98 patients, I'm just reading off the screen in front of me. I haven't got one of those photographic memories. 59 treatment naive and 39 previously treated. Of those previously treated, had any of those had DAB tram as their treatment before? Or were they all TKI naive?
I don't know that off by heart.
Okay.
My sense is they were all treatment naive. I think they had chemo or chemo IO first line, but I will check that.
Yeah. No, I don't know off the top of my head either. Yes, and I think it's very important that because that was a registration study that came out, and it is a different combination different options we have for these patients. That remains unlicensed, and I guess it remains the case that still, when you now progress on dab-tram, you will be going for chemo IO, then moving down towards taxanes outside of other clinical trial options. Do we have, or do you have a handle on brain mets and BRAF? Should we be as concerned about it as we are, for example, with ALK? Should we be screening differently? And do we have any data on activity of these targeted drugs against the brain?
Yeah, that's a really good question. My understanding is from that very first Blanchard study, I think there were only 4 patients with brain mets. So our understanding of how these drugs work in the brain is very limited. The incidence of brain mets, my understanding is more common in the class 2 and 3 population than in the class 1. But in terms of response, very little data out there.
Yeah. Okay. So, I mean, I think it's always good with anyone with a mutation-driven disease to do your cranial imaging. I know it's a little contentious, and some people very reasonably say, well, would you want to know? But I think you can do so much. It's important to know. And I think we would say to our colleagues, keep an eye, even if you haven't got brain metastases, or sorry, the patient hasn't got brain metastases, then be doing your routine MRIs to keep an eye if you can do that. I just had a quick squiz whilst you were talking there at that data we mentioned, the new combination with encorafenib and bimetinib, and all the prior treated patients had not had a BRAF targeting drug. So we don't really have any data yet on targeted BRAF drugs after targeted BRAF drugs at the moment, is my understanding.
Yes.
Okay. What do we have anything new on the horizons? I mean, we have these non V600 mutations. Are people exploring drugs for these? Will they just always be the also-rans? You know, you're as you say, the class 3A mutations you're going to see when someone's actually got a cancer driven by KRAS. So we might be ignoring them. Are there other options that you may be aware of, or products in development?
Yes, so there are several agents, but they're very much an early phase clinical trial. So there are phase 1 studies of dedicated agents for the for class 2 and class 3. Okay. But they're all, some of them are mouse models, some of them are phase 1. So nothing quite at the level that you know, we're going to change what we do, but certainly there are agents in development. The other area that I think is important to highlight is, how does this factor into stage 3? So that's something that's come up for me a couple of times, where incidentally I found a patient has a BRAF altered stage 3, and do I want to give durva in the adjuvant setting? And that's a tricky one. To be honest with you, I have in the class 2 and 3s adopting the same paradigm as the stage 4 paradigm, that these are really more, you know, a typical, you know, kind of a lung cancer, and I'm going to give the durva anyway. In the V600 population, it's a little bit more of a discussion with the patient. In my experience, I've had 1 or 2 of these, and I don't know, I seem to have a BRAF target on my forehead, but anyway, and in those instances, I actually gave it as well, and the patient did okay. But there is a good paper, Reduvitz and colleagues, European Journal of Cancer, from a year or 2 ago, examining the responses to durva in the stage 3 population that includes some of the BRAFs. And that's the only data I've actually seen published on it. So
there's so little, isn't there? Because they were, if you look at the exclusion criteria of those studies, BRAF wasn't as an exclusion criteria. The only exclusion criteria was EGFR and ALK, and back in those days. I guess their smoking history may also be relevant. If you had your patient with a BRAF mutation, but they smoked a lot, you might be more inclined to go down the adjuvant immuno route. And if they're a never smoking V600E mutation, then perhaps you wouldn't.
Yeah, that could certainly factor into it. The thing with V600 is that half of the, you know, some may still be smokers. It's enriched in the never smokers for sure, but you can still get a V600 smoker.
Yeah, that's a good point.
And that would be tricky, I would say.
And I guess it's to have an open discussion saying, well, we can go down this route. There may be less activity. And I think as long as everyone is aware of the pros and cons of what you're doing. I think that's very reasonable. Okay, I think that probably brings us to all things BRAF considered. My summary would be, make sure you are doing proper NGS on your patients. Make sure as much as you can, you have your results before making your treatments. If you've got a patient with a BRAF V600 mutation, be reaching for your DAB-TRAM at the moment. That's the only licensed combination. But keeping eye out for new data and new stuff coming through. And if you're unsure about your mutation, look it up on the internet, speak to your molecular biology colleagues. And if you do have someone on DAB-TRAM, they're going to get some pyrexias. Make sure that they know what to do, and make sure that your colleagues know what to do when they phone up at 3 in the morning with their pyrexias. Thank you very much, Jarushka. That was a tour de force. We're hitting just under 30 minutes, which is the perfect timing, because that's when my attention span begins to wane. So I will thank you very much for your contribution. Just to remind people listening that there's a number of different podcasts on the BTOG website, but also wherever you get your podcasts from, as they say, going back for almost a year and a half now. So do listen to some of those. We will be recording another couple in the near future, focusing on other rare mutations, and we hope you can join us then. Jarushka, thank you very much indeed.
Thanks, Tom. Great to be here.